Yeah, it's very variable. I mean, the problem we have is if we had a crystal ball, it'd be easy. And the way we choose to do certain things, like a stem cell transplant, is we have to base our approach on previous experience, usually based in trials which are performed overseas. We enter some of these trials ourselves, enter patients into them, where you take people, I mean, the reason we think stem cell transplant is a good idea is that overseas in the past, people have, with myeloma, have been basically randomised. That means a coin gets tossed by a computer and half of them got a stem cell transplant, half of them didn't, and you follow them. And then after some years, I mean, it's monitored very closely, but after some years it becomes apparent there's a difference. And that's how we know whether one thing's a good thing to do or not. It's only averages though. I mean, there are people who don't get stem cell transplants who, you know, I've looked after for ages, and people have a stem cell transplant, the disease is active within a few months of it. And if we'd known that, we wouldn't have done the stem cell transplant in that person. And we do have some ways of, we're increasingly knowing how to predict who's going to do well with a stem cell transplant and who isn't. So,
fibrosis showed up when they did the bone marrow biopsy in that on me, and they said that it came back so that the result was inconclusive, so they'll have to do it again down the track. So
what was it that showed up? It was fibrosis, yeah. Myelofibrosis is a condition that, it's one of these myeloproliferative conditions that I mentioned. The problem is that in that condition, the genes in some cells in the bone marrow are altered, which makes them produce more of that stuff called fibrin or collagen. So it's that, you know, that stroma which supports the bone marrow. There is a little bit in a normal bone marrow. In myelofibrosis, there's far too much of it, and it's produced by blood cells. They stimulate the production of that. And so there seems to be a mutation in a cell that causes that. That's quite a chronic condition, and it eventually leads to enlargement of the spleen in some people, and eventually causes anemia, which requires transfusions. In the early phases, it can be quite hard to distinguish that. So that we often have to do a bone marrow, so it looks like that's what's going to happen, but we don't know. And the problem with all of these things, I've often said to people when you're sort of talking about percentages and facts, is you're either 100% alive or you're 100% dead. You know, you're either, you know, so if we say, well, we've got a 50% chance of curing it, well, you know, if you're in that 50%, that's great. If you're not, it's not so good. And it's odds. And a lot of what we do when we treat people is lowering the odds. It's a bit like, you know, the sweepstakes that we, you know, when the Melbourne Cup comes round and you put your hand, I don't know if you've been at work, someone brings a big bag and you pay them $1 and you put your hand in and pull out a horse, you know, out of 20 horses. Well, when we choose to give people treatment or discuss treatments with them, it's a bit like going to the newspaper and reading up and saying, I don't have to put my hand in a bag, we're going to bet on the favourite. It may not win, but I'd rather bet on the favourite than the outsider. So when we choose treatment, that's kind of what we're doing. We're trying to improve the odds that this is the best treatment for you as an individual. Okay. Now, when it's sort of, we do a bone marrow, it's not always as straightforward as I've shown. You know, to get these pictures of a nice example of one disease or another disease, you know, that's easy, but in the reality, we do bone marrows, we say, well, I think this might be myelofibrosis or it might not be, and the only way to tell sometimes is to wait and see. We don't usually have that much difficulty diagnosing acute myeloid leukemia, chronic myeloid leukemia, because they're more obvious, and usually the changes that occur in those diseases is quite rapid, if that makes sense. There's probably several factors. We are getting better at detecting them, so if you look at, say, the cancer registry, we also get better at reporting them. So, you know, the cancer registry, you're supposed to report all new cancers, including leukemias, to that. And I think people report better, so it looks like there's more of it, where in fact just there's more people, you know, we're reporting 90%, we used to report 50%. That's one factor. We've got a growing population, slowly. New Zealand's population grows, so when you've got more people, you're going to have more disease. We have an ageing population, and most diseases are more prevalent with age. Almost all haematological diseases are more common as you get older. Particularly some of those things like chronic lymphocytic leukemia are very much more common in older people. But even acute myeloid leukemia, multiple myeloma, they're all more common in older people. So that is an impact as our population ages. But there are some diseases we think are increasing. There is a feeling that lymphoma is genuinely increasing as an incidence. I think there's a feeling myeloma may be. Not so sure about acute leukemias or chronic leukemias, but there's a couple of diseases which we think, I mean, they're the commoner diseases too. Lymphoma is the commonest sort of blood cell cancer. Myeloma is the second commonest. And so we've probably got better figures around them. And if that's the case, I mean, there's a lot of interest in this, and there are surveys in terms of trying to work out whether there's some occupational thing or some environmental thing we can change. I should have mentioned for the There is exposure to benzene increases the risk of certain types of leukemia, and that's been shown in some factory workers in the past. I think leather factory workers, and I think in some big factories in China they've shown exposure to benzene increases the risk of myelodysplastic syndromes, which are like a pre-leukemia type disease.
Benzene is in petrol.
Well, no, benzene, there's not much benzene in petrol. I mean, petrol was called benzene, but there's not much, and I don't know there's a lot of evidence that exposure to petrol as we have it. But in these factories and these industries, certainly the leather industry, as I recall, and I think in some Chinese factories, there's quite a lot of exposure to benzene, which is a specific chemical. Although there's a little bit in petrol. It was used as a term for petrol. I don't think there's much in our modern petrol. But I mean, you know, no one's going to go, well, people are going to go sniffing petrol, but I'm not. You know, so it's not a good idea for all sorts of reasons.
I've asked the question, why do you get it? It's the only thing I've got. Everything's okay. Now, you'll say, well, we don't know.
It's bad luck.
But hang on. After 9/11,
Yep.
as a result of that, a lot of firemen, a lot of policemen are getting multiple myeloma.
Yeah, I mean, it's.
Research that.
The people will be looking at that. I'm not familiar with those data, but people are looking at that. There's nothing that would change what we do at this stage, to my knowledge. Now, I try and keep up, but I don't know everything, obviously. No, that's the first time I've heard that, for what it's worth. When I say bad luck, the other thing to think about is every cell in your body has the potential to become malignant. Okay, every cell's got genes, and if the wrong thing happens to those genes, that cell will start to grow out of control. If you say that the events that lead to these diseases are really rare, the critical mutation that will make that cell actually change and become malignant, because as I say, most mutations don't do anything. Okay, it has to be an absolutely critical part of the gene that changes the expression of certain proteins that makes it become malignant. If you think of that as like, so as rare as winning lotto. Okay, you got more chance of winning lotto if you've got, a ticket for 80 years than if you've got a ticket for 3 years, So that's why we think cancers get more prevalent as you get older. It's just bad luck to a certain extent. Plus, I think we think that many cancers probably are controlled to a certain extent by our immune system. So little clones of cancers are starting off and our immune system can get on top of them. And it may just be bad luck at a certain time. You may have another bug happening or something allows it to get away. And as we get older, I think our immune system deteriorates a wee bit, and that ability to fight these sort of cancers deteriorates a bit. And the other point I should make is that cancer is not a single mutation that leads to cancer. It's actually a multi-step process. So I've simplified it here saying that this mutation makes that happen. It actually, we think at least 5 to 10 separate mutations that actually lead to the cell finally becoming malignant. And my guess is all around our body we've got little clones of cells which have sort of started that process. They've had 1 or 2 hits, but they actually need 7 or 8 hits to really become malignant. And we do sometimes see those hits, so that we have these conditions like myelodysplastic syndrome, some of these myeloproliferative disorders, where the first couple of hits have occurred, and we can see it because it causes the cells not to grow up properly in the bone marrow in myelodysplastic syndromes, or too many red blood cells in these myeloproliferative disorders, or too many white blood cells. That's, if you like, they've had the first couple of hits and we can see it, and we know that they're more at risk of developing leukemia. Okay, but it's not inevitable. So to get the other hits doesn't necessarily follow. If that makes sense.